Yeah. Good morning, doctors. On behalf of Sun Pharma Spectra, I would like to welcome on this knowledge dissemination series 15th IFS Fertility Connect webinar on genital tuberculosis diagnosis and management. I would like to welcome Honorable Secretary General of IFS and speaker for today's webinar, Dr. Divya, can I have a CV of Dr. Nina Malhotra, ma'am? Yeah.
Yeah, it is on the screen here.
Yes. Madam is a professor in ART Center, Department of Ops and Gynae, AIMS, New Delhi. And ma'am is a recipient of many awards and published 145 journals in peer review. Ma'am, I'm really honored. I would like to hand over this session to ma'am.
Yeah. Thank you, Prachi. Can I share my screen?
Yes, yes.
Yes,
Yeah.
ma'am. Yeah.
Good morning, everybody. At the outset, I would like to express my gratitude and thanks, especially to Prachi, Manojji, and all the individuals from the Spectra division who have been very kind enough to give IFS the opportunity to spread this knowledge through this platform, this learning platform of Fertility Connect. So without taking much time, I would move forward into a very, challenging topic, which is of genital tuberculosis. Obviously, on the international literature, we don't get much except from the Indian subcontinent or a bit of from the Southeast Asian side of the world, because this is a problem of developing countries, including Latin America. So I just want to take this lecture not just as a didactic. I have put in place a few questions that I have put forward, as we say in our day-to-day practice, and also got some interesting case scenarios which we can sort of take, and then we can have the interaction. So this is the kind of WHO chart which comes, and I don't think I need to tell that tuberculosis is a problem where it's a leading cause of death in women worldwide. And these figures may be a little old, but then this still gives us a very glaring look that women in the reproductive age group face the challenge of tuberculosis, and they are predominantly from the developing countries. Now, if I say 1/3 of the world suffers from mycobacterial tuberculosis, not just genital, then I think it is important. This is not just extrapulmonary, it's entirely pulmonary. So somewhere or the other, 1/3 of the world may be suffering. Again, it's a common cause of infertility in the developing world. Just numbers are varying because 15 to 19% is coming from data, which is in India data coming from hospital-based studies. We actually do have very little from the community-based data, but figures go very high. We look at papers in the 80s and 90s of almost 50% from hospital statistics of infertile women having tuberculosis. Now, the tuberculosis, I know that the spread is secondary from the extrapulmonary tuberculosis when it comes to the genital organs. It's spreading secondary from the TB elsewhere. And we don't need to kind of know this. This is all that's understood. Ascending infection is far limited. We know that the sites would vary, but the commonest site is the tubes that it comes. Why I highlighted endometrium is that if it's in the tubes, we probably can do something, probably do an IVF for these women. But when it strikes the endometrium, then that's where the real challenge for clinician lies. Needless to say that it also affects the ovaries, where we have diminished ovarian reserves, and also rarely in the vagina or the cervix. So how does, I just thought I'd just get it as a question, how does it affect fertility? Well, of course, when it affects the tube, then it is causing all these kind of pathologies, including a hydrosalpinx, two blocked tubes, and of course, as I said, endometrium, which is a challenge, basically presenting as implantation failures. And women, when they are affected with tuberculosis, they have diminished ovarian reserve. For endometrium, I think this is something which we all understand. It's a reversible damage when probably we can help these women. But when things go beyond our control, it's irreversible, is when we get scarring, adhesions, and Asherman syndrome. And this is some of the papers that I want to show that when it is not even directly affecting the ovaries, i.e. if it is tubal also, there is sufficient data enough from our works at AIMS and also from Dr. Padma Jirge's publication, both international, which say that women who had tuberculosis had diminished ovarian reserve when they undergoing IVF or infertility treatments. So Again, the big question is that we know the cytopathology, we know that it's affecting the tubes, it's affecting the endometrium, then how do we reach the diagnosis? Now, obviously, unlike pulmonary tuberculosis, where we'll have an individual having symptoms, maybe running fever, having cough, or maybe sputum, which can pick up the acid-fast bacilli, women with genital tuberculosis, by and large, are asymptomatic. And it's only when they come to us asking help for infertility that we pick up through some kind of molecular methods, or less commoner, the conventional methods. So for this matter, I think it's very important for us to recognize how do we define it's a tuberculosis, which could be active, latent, or a healed tuberculosis. I.e. healed is what we really see when the disease has caused damage enough, like in the endometrium or in the tubes when they're completely blocked, the lead pipe tubes. Active is when we can pick up the organisms right in the source of the tissue that we are investigating, be it the endometrium or the peritoneal fluids. And of course, latent is again a very big challenge because we really don't know how long the latency and what are the latent tests which would say the disease is latent. And this is what I would say people who are really interested to should go on to the Index TB guidelines, which have come from the Ministry of Health and Family Welfare. They're on the website of diagnosing extrapulmonary tuberculosis, including genital. So if we look at the case definition, it is a case which is presumptive TB, which can be clinically diagnosed and bacteriologically confirmed, which is i.e. active tuberculosis. May look very nice in this diagram, but not actually very easy to somebody will take through. So a clinically diagnosed the case who may be negative on a microbiology. Now we should understand what is microbiology. That means when you do a tissue, you're sending this tissue for a histopathology, AFB, and cultures, which could be the LJ cultures as standard, or it could be the liquid-based cultures that we are doing as BACTEC. But very important, we should also think of a patient who may be negative because we know that this bacteria is possibacillary, i.e. the bacilli are very limited in the endometrium that we take the tissue from, and contrast to the sample that we take in a sputum for a pulmonary tuberculosis. So it could be negative on a microbiological test, but there is a strong suspicion because there is something like imaging, which is showing some findings like an HSG or maybe a CT finding. And of course, there are diagnostic ancillary tests, and I will tell you what are the diagnostic ancillary tests, i.e. the use of endoscopy. So for a diagnosis of, these are just picked up from the guidelines. So if any one of them are present, and this applies for extrapulmonary tuberculosis, including the genital, female genital tuberculosis, any gynecological specimen which is testing for AFB on, and what do you mean by a specimen? A specimen could be endometrial aspirate, which is the most common, or the endometrial biopsy that we do most commonly on a microscopy, that is on doing an acid-fast bacilli, or positive for culture. And I said culture could be LJ or liquid cultures, and any gynecological specimen which is consistent with the finding of genital tuberculosis and histopathology, like we did a hydrosalpinx, we did a surgery, we did a laparoscopy or a laparotomy, and we found there was a teomass when we removed, and a histological examination, we get typical giant cells which are peculiar of tuberculosis. And of course, in the extrapulmonary, we also put in a laparoscopy which is showing typical of tuberculosis. And I'll tell you what are those typical findings. So what are the typical findings on a laparoscopy? This is a kind of classification which has come from the works done at Ames in the times almost 20 years back, and we are respecting this work over a lot of publications that have followed. A definitive diagnosis on a laparoscopy coming when you see classic tubercle localizations, which may not be very common these days because we are now getting to see more of cases of probable, i.e. something like an encysted fluid collection, dense adhesions, something like hydrosalpinges or teomasses. So these are something which we put them as probable. Possible tuberculosis, that means there is a possibility when you have flimsy adhesions, corneal blocks, fimbrial blocks, because these are findings that could be present even when there is a lady who has a chlamydia or infection like pelvic inflammatory disease. And of course, this is how we grade a normal finding of laparoscopy or an incidental. So definitely, if there is a definitive or a probable, you are going to put this woman on the diagnosis of a tuberculosis, irrespective of a negative finding on a histopathology, negative finding on an AFB, or a negative LJ culture, or a negative BACTEC culture, because we know that the disease is possibacillary. So for a diagnosis of a tuberculosis, definitive is certain, indeterminate is when there are probable and possible, and normal are when there are findings which don't suggest tuberculosis. Now, latent tuberculosis is a state when there is an immune response, a state of persistent immune response to stimulation by the MTB antigens, but there is no evidence which is clinical, i.e., she doesn't have any manifestations other than infertility. But then what is the way to diagnose? Yes, certainly there are no gold standard methods of diagnosing latent tuberculosis. So what is the take from the WHO is that as of now, co-latent, there is no exact defined test for extrapulmonary tuberculosis when it comes to latent, but they say that prevention of active disease by latent TB is critical component, and that's what the WHO strategy says on the published data on 2018. So again, therefore, when we know that we don't have a latent diagnosis, the question arises, should we screen all women for tuberculosis when they come for infertility? Because that's when they're coming to us. There'll be rarely somebody who comes with fever and a TO mass or fever with some kind of presentations like, which suggests like the pulmonary cox, but no, that doesn't happen. So are we going to be selective or are we going to be routinely choosing? I think this is again a very, very big dilemma. So as of now, I think most people in the corporate hospitals would not really believe in doing routine screening, but I think working in a public hospital as AIMS, we are routinely screening women because we do get a positivity rate still of around 2 to 5% in the population that we are seeing our patients. However, I don't think there is any guideline to be very routine or it's mandatory, but I think each one can sort of be selective. If you get patients where you feel that there are atypical findings on an ultrasound or you feel there are implantation failure, it calls for looking in for tuberculosis besides other investigations. So again, if you look at it, that if that is the way we want to do a screening, i.e. when we do an endometrial biopsy or aspirate, the question arises, how do we really send the sample? What is the way we're going to do this testing to confirm it's genetic tuberculosis? And is it very straightforward and simple? Because that's a big question. That's the reason why people are not very happy to offer tests, because they say at the end of the day, we can't make any definitive diagnosis when all tests come negative. So I think the important thing is that we have got some ancillary tests and some definitive tests. So let's look at it, that what are the definite ways? Definitive ways are definitely endometrial, that is doing a biopsy or an endometrial aspirate. We can do imaging, which can be varying right from HSG to ultrasound. And of course, endoscopy, which is, as I said, laparoscopy, where we have defined findings. But when we combine it with hysteroscopy, then laparohysteroscopy is also part of a definitive diagnosis. So the ancillary investigation we see is that we are doing this, but again, an raised DSAT does not suggest tuberculosis. It is just a pointer. A positive tuberculin sensitive test, which is Montague's test, may not be confirmatory, but then it's ancillary. So doing serodiagnostic tests like IgM is not advisable because they are not to be used for diagnosis. Again, if you're using IGRAs, which is quantiferon gold and quantiferon golden tube and the T-spot, again, they have got limited value in a developing countries like India because most of us are actually immunized and we have a BCG vaccination. So this will again give a lot of false positivity. However, if there's somebody in US, then IGRAs are used as a method to diagnose latent tuberculosis. So when we come to the diagnosis, again, I got this in the slide here, that IGRAs, and this is coming basically from the guidelines coming from WHO. But I just want to say that what is IGRA? IGRA is or a tuberculosis sensitivity like Montague's or IGRA. What is the difference? They are basically both the same, test, because they are testing the immunity of the individual. But the only advantage between a Montague's test is you require 2 visits as against an IGRA, which can be done in one go. But mind you, the cost of these tests is prohibitive as compared to Montague's. So I would really not dwell much on this. So they say that in the low income and the middle income countries, this is again not going to be used. However, it is recommended in most advanced countries where it is used to diagnose latent tuberculosis. And therefore, we have to be very, very cautious when we offer them. So coming on to specific investigation, I said is a convention. How do we do endometrial aspiration or biopsy? We can send this tissue for a conventional test or for molecular, and I will dwell on what it is. And on the imaging, it could be an ultrasound, which is best transvaginally, HSG, CT, MRI, and now some case reports where they said they could pick it on PET. However, I would never recommend anybody to go in for these costly investigations like PET to diagnose tuberculosis, CT, MRI to diagnose tuberculosis. Only these were case reports when you're not able to reach to a cause, they are picked up because there will be a lot of cost and also a lot of dilemmas in the mind of the patient. And of course, endoscopy is laparohysteroscopy. So if we come on to simple things as endoscopy imaging, I think there's some findings which are commonly being described on our experiences, is the presence of fluid in the pouch of Douglas or encysted collections, pelvic adhesions, ovaries which are stuck. There are unilateral, bilateral masses, adnexal masses, hydrosalpinges, some echogenic thin endometrium, intrauterine adhesions, and if you have the Doppler facility, then the presence of a decreased subendometrial blood flow. So these are some of the imaging findings, and this is how it is. Maybe fluid in the endometrial cavity in a woman who had tuberculosis, something like calcifications, which are suggestive of tuberculosis. And these are typical findings of intrauterine adhesions where you have breach. And these are all coming from our department ultrasound machines, where you can see how hyperechoic, hypercalcific causes Asherman syndrome picked immediately on an ultrasound. And we knew that we had to put in a scope to diagnose or break these adhesions. And this is how the adhesions may also come sometimes like breaches or cystic spaces. So these are something where you have to think tuberculosis only, then you could be able to pick them on ultrasound. Likewise, on the HSG, we have all this findings and features, and I think I will not really take you individually, but these are not uncommon when you see beaded appearance or you see there are irregular calcifications. When you do the, just do a HSG, you are also getting this golf club appearance or a Maltese cross and the leopard skin. These are all the findings that you would get depending on how far the damage is. And these are some of the findings. You can see this is an image which I picked up from one of our older patients. We don't see it very common now, but typically beaded tubes to these convoluted tubes where there were typical hydrosalpinges. This is a tobacco pouch again, the way it presented like a hydrosalpinx. And again, thin, very thin tubes which are showing a distal block, and they were stem pipeline beaded tubes. And this patient, if you had see, this was also having an intrauterine adhesion. If you see the arrow pointing there. So basically, if you look at the findings on the tubes are very classy, but however, endometrium can also be picked on HSG when you can get synechiae, you can get filling defects, they can have a T-shaped or tubular and obliterated cavity, and that's very typical. So if you look at this is a shrunken cavity. Again, a very old picture which I had to literally look around, almost dig out from a patient who came to us 15, 16 years, don't see it very common. Again, a spickled irregular outline. And very typically what you get is when you do an HSG, you get extravasation of the dye or extravasation because there is a block right at the corner. So now then the question comes in that, am I going to send it for the conventional test? What are the tests when I take a sample like from the endometrium? Well, it will be a sample where the conventional test will be histology, i.e. looking for the giant cells, AFB, which is looking at the acid-fast bacilli on the smear, and of course culture. So these are the three conventional tests. But then what is important is, do you really think that a patient who has tuberculosis will give you a positive conventional test? Well, I think it's something which you have to realize that just 5 to 7% of your patients who have actual tuberculosis will be picked up on these conventional tests. The reason is that this is a possibacillary infection, an infection where the counts of the bacilli are as low as just, maybe 100 bacilli, less than 100 bacilli, because to pick an AFB, you need 10,000 bacilli, you need 100 bacilli for culture, and therefore, that this may not come very easy. And very important, when you do histopathology, you have to realize that a granuloma takes up to 3 weeks, and there is a periodic shedding of this endometrium that takes place. So by the time you take the patient for an E or a biopsy, she's actually shed off that endometrium which was rich in the granuloma. So what is the best thing is do a premenstrual or a before the period. So time your biopsies, time your endometrial aspirate in the premenstrual phase. And therefore, if you really put it together, you can see that conventional tests by maximally can pick up only 15 to 20% of cases, whereas molecular have a better pickup, including the RT-PCR or the DNA PCR, which we are doing commonly. So therefore, these are the challenges. And therefore, if there is a patient who's negative, are we calling her negative? No, she's not negative, because in that case, instead of these so-called conventional, I'll have to come into the non-conventional or the molecular or the endoscopic methods, which will be needed, or at times even have a combination. I know the conventional are negative, so I'll combine with the laparoscopy, hysteroscopy, or look in. And that's the way we do it. So what are the molecular methods, and are they very easy? Are they reliable tests? So if these are the conventional tests, as I named you, the three of them, staining, histology, culture, the molecular methods are basically nuclear amplification tests, which are basically DNA PCR, a gene expert, LAMP, and LAMP. I would say that up to an RT-PCR is what we're doing, is what is standardly or easily available to us in the market or in labs. Gene expert may be available, but gene expert is nothing but similar in its predictive predictive value to a RT-PCR. LAMP and LAMP are other research settings, and we don't have much lab available and don't have much of data on this. And again, a molecular method is a rapid culture, which is the BACTEC or the midget test that we do. So DNA PCR is what we commonly do, and this is what we commonly do in the labs. Now, again, some bit of publication. I want to say that a DNA PCR does not always mean that this is a woman with tuberculosis, because if she's had a tuberculosis in the past and she's taken ADT, the DNA are dead bacilli and they will still be coming positive on the sample. So mind you, a DNA PCR could give you a high false positivity because it is the bacilli which are being shed actually, or have been treated, but since they are dead, they will be shut off and be picked up. So one has to be very careful on this. However, if you do a nested PCR, then this could be improving the sensitivity. However, a nested PCR may only be available in research settings. Now, so if we look at the advantages, yes, the advantages are that they can pick up to less than 10 picograms of DNA, and that sometimes becomes a nuisance for us because you just require just 1 to 10 organisms, considering it's a paucibacilliary infection. But the big disadvantage is that it will pick up even dead bacilli, and the false positivity rate is very, very high at 10 to 12%. And nobody would like to have a false positivity as high as this. So again, on the BACTEC, however, if you look at the cultures are almost very reliable. They have a good advantage that they can be picked up faster, because an LJ culture takes 6 weeks to come, as contrast to a liquid culture from BACTEC, which can just come in 10 days. However, if it is positive, then the sensitivity is really good. So I would just say there are some newer molecular methods which have been approved by the WHO, the lead microscopy, the gene expert, which is automated real-time nuclear amplification test. This is also nuclear amplification test. And again, the manual methods of the molecular testing, which is set up when gene expert is not possible. And this is loop-mediated isothermal amplification test. Now, this is also, again, a research setting, and I would say it. So I just thought I will get a word about gene expert, since we know that there is RT-PCR, which we are relying on, a DNA RT-PCR. I do not want to touch the word of our RNA PCR here, because RNA would be more reliable, but then it's very challenging to do. So not much of publication, some work from Maulana Azad, Dr. Sudha Prasad's team, and Dr. J.B. Sharma's work. But this is something which is coming as a clinical. Even we have got our own ICMR trials where we published, and our gene expert data is in the process of publication. So this is a test which was done, and the unit looked in women who were infertile. They looked at 176 women which were in the reproductive age group, and they did all the tests, including PCR and gene expert. And what they found, that they had just 18 patients who were positive using the gold standards. So you can imagine this positivity rate is with all the gold standards, which included laparoscopy, also was close to 80. And in what they found was a gene expert was just had a sensitivity of 11%, which is far too low as compared to, but its specificity was 100%. That means if it is a gene expert positive, it is definitely tuberculosis, as contrast to picking up just 11% of cases. And since we don't have much data, I think we will need more data. However, we are publishing a multi-centered data which we did as part of our ICMR trial from 5 centers. We have 1,500 samples where we did gene expert. And what we got from our unpublished data is that there was a very close correlation between RT-PCR and gene expert, almost 99% concordance. So those tests which were positive for a gene expert, RT-PCR, were also positive for gene expert. So having built up, I thought, let me take you, not just giving you lectures, but talking to you with case scenarios to make this difficult or a challenging subject more interesting. So I just got 4 or 5 cases to share how do we go about. So this is not an unusual scenario. There's a 12-year-old lady who comes with, this is may not be very common, but this is what we still get to see in AIIMS, even in the present day and age. A lady who comes with, tubercular endometritis. She took ATT, and this was almost 4 or 5 years back. And she completed ATT, and then what do we do? Should we really take her up for another VA, or should we treat she's completely treated or not? Well, there's a big question. And do we do anything before we really jump in? Can we use some other imaging? Should we do some ultrasound? Well, certainly in this patient, should we already put an HSG or laparoscopy? These are the common questions that one would do. She's already got ATT. What do I do? So here it is, and a very big challenge. Should I really do an endometrial aspirate again? So since this patient, and I would tell you what really happened, this patient had come to us, and what we did is she had gotten HSG done already, and I will share you the images. These are real case scenarios. So what we did an endometrial aspiration again on her, because we were not very sure whether she has been consistent with the treatment, and this treatment was almost 4 years back. Again, we got everything negative on the conventional test. Granuloma was not there, AB was negative. What we got was a positive DNA PCR on tuberculosis. Now, mind you, this could come from dead bacilli because she's treated. So we were not very sure whether this is a dead bacilli or an active bacilli. Again, a big question. But you look at her, HSG, which she came, and she had this typical tobacco pouch. Now, these days, this is a rare, and I kept this image with my, I clicked the picture and I thought this is something I can show my undergraduate and postgraduate. So this is typically a hydrosalpinx. She had beaded appearance. Can you see there are beads also, and there's a tobacco pouch. So this was clear cut. We didn't have to really do a big decision. We knew we have to put in a scope because she was infertile. We did a salpingectomy prior to her IVF. But the big question was, should we give her ATT before we have taken a decision for an IVF? Well, I think this is something which, again, clinicians have to consider because there's no clear-cut answer. She's a DNA PCR positive. She's wanting infertility. And if I get good embryos, will I wait for her to have implantation failures, or should I give ATT? I think this is something which we have to individualize or maybe consider in light of her DNA positive PCR. And I think judiciously, we believe in giving such patients an ATT before we go in for a costly treatment like IVF. So I think this is what I want to stress, that when we have a possibacillary infection like tuberculosis, we know that even though she's taken treatment with INH and the like of rifampicin, pyrazinamide, there will be an amount of dormant bacilli. And this is what is called as an ongoing mycobacteria, which will be simmering inside the endometrium. Now, when she is undergoing an IVF, we certainly don't want the simmering bacilli there. And therefore, it's a good idea to give these women 6 months of ATT before we really embark on IVF. Now, is there any recent change in the drug therapy of tuberculosis in the RNTCB program, which is the Government of India program? And what is the take on extrapulmonary tuberculosis, which includes genital tuberculosis? So if it's a recently diagnosed, you give them 6 months, which is 2 months of 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol, and then you continue 4 months with INH, rifampicin, and ethambutol. However, if she's previously treated, like in this case, it's a good idea to give a longer therapy, and this is how the thing is being described. Also, there's something which the Gazette of India has been published. It is there, and it is not recent. It clearly says it came in the year 2018. It's again there that if you have a patient who has been diagnosed recently of tuberculosis, then you have to report it to the authorities, the SEAM of the district, or because if you fail to do that, you may get punishment, which could be meaning anything as is mentioned here. Now, again, a big challenge comes that we just have a PCR positive patient. And do we really give them ATT to all if we don't have other findings, or should we kind of, not give them? So this was a randomized control trial, which was done by Dr. Kaplani's unit. This was way back in 2013 or 14, and they published it in 16. This was an ICMR funded project. And what they did was they gave, these women randomizing into just on the basis of positive PCR to do whether ATT should be given. What they found was giving an ATT in these patients, they conclude that did not give that a positive DNA PCR should be given. And they came out from the data that the group who did not get ATT also had a similar pregnancy rates as compared to those who got. So this was one work. So, this side, this is a randomized trial. However, if you look at a paper which comes from Dr. Jindal, this was again published a long back, and this came in the year, I think 2012 or 2013. And this study actually tells a different story, and her story is not randomized. This paper is not randomized. It is their publication in which all the positive PCRs, they gave ATT. And what they found was that they definitely showed that the median time to pregnancy, mind you, this is not IVF. Both the papers are not looking at IVF outcomes. They're looking at people who had positive PCRs, and they were asked either spontaneous conception or ovulation induction and IUI. And they found that when they gave ATT, what was very significant was the median time to pregnancy was much lesser, significantly lesser, with a confidence interval you can see which was definitely different. So what Dr. Umesh Jindal's paper says is that when you give them ATT, even on the basis of positive PCR, you're actually reducing the time to pregnancy, i.e. improving the implantation, improving the medium. Now, this is another case where, we always think that, oh, this is a problem of the poor people. No, this is A patient who came as a corporate lawyer to me. It's a long story. I think this must be now 7 years back. Upper middle class, primary infertility, routine estimation, absolutely normal. And like when we do, it's a part of our workup. We do all EAs, and we did it. Her samples were negative for the conventional test, but when we were offered her an HSG, there was a corneal block. Now, what is the plan? Obviously, laparoscopy. And so, when we put in a scope, this was the findings. And when I showed the images to this lady and told her that, look, these are suggestive of tuberculosis, she was quite horrified. She said, how can I have tuberculosis? I come from a different strata of life, but this can happen. And if you look at it, there were adhesions between the omentum. She had periovarian peritubal adhesions, and there were also evidence of a laparoscopy where, as a part of workup, and this is part of our big ICMR trial, so when we were looking at patients, we were even sending peritoneal washings from the pouch of Douglas. And what we did, we found that the DNA PCR was positive in the peritoneal washings. So what had we to do? Nothing, but we gave her ATT because there was, a reason, because this is definitely a disease from the tubes has spilled into the peritoneum and picked up on a PCR. Should we start ATT? Definitely. This is a patient where you need to start ATT because there is laparoscopic features which are probable, and of course there's a positive PCR. And what we did is, when we gave her ATT, in fact, as soon as she finished ATT, because there was a tubal damage that she had, we took her to IVF, and this woman had a pregnancy. So again, some success stories, probably I can't say they're anecdotal, but there's definite science around them. So another case, we just have to make this a little bit of discussion and interesting, that this is another woman who was 32-year-old, had a long-standing infertility, got a workup, semen analysis is normal, tubes were patent, and this is typical. An unexplained infertility comes to us now. If you were in a private setup, you would say, why not push her to IVF straight? But since when they come to a public hospital like ours, where we have a defined protocol, we would certainly do an endometrial aspirate for all the patients. And what was interesting was everything was negative, the conventional as well as a TNA PCR. But then as we thought, let's put in a scope, and what we found was this. If you look at it, on a hysteroscopy, she had typically, the periosteal adhesions were there. And therefore, this is again a reason for us to start thinking. And if you look around, if you look at the image of the endometrium there, that's also showing something like chronic endometritis-like picture. And this is something which is very peculiar in these patients. Now, again, a question, do we give them ATT or not? Well, really, I will just take you. So when we did our laparoscopy, everything down below was normal. Everything looked good, the tubes are good. But as we turned the endoscope towards the liver, typically perihepatic adhesion. Now, the question is this chlamydia? Yes, it could be chlamydia, but that's the fig. But then why should a chlamydia give you periosteal adhesions? So I think you have to be very mindful of not just one finding, but you have to put in comprehensively. And when we did the peritoneal washings, the PCR was positive. She was started off ATT, and this patient was pregnant while she was taking in the 4th month. So, again, I will say that these are some patients that I want to say that to start ATT, you need to have a justification. You can't be empirical, give them because they're PCR positive. But if you have a laparoscopy or a hysteroscopic findings, they corroborate, then it makes a good ground and a reason to give them ATT, because we know that this treatment would be useful. Now, the question arises, do we put in a scope for every patient? No, it's not easy, because laparoscopy is invasive, it's costly, it has got its risk of anesthesia, risk of, putting in a port and also injury to structures. But what's very important that we have learned in our experience is when we don't get answers, i.e. we don't get conventional positive, or we just get only the molecular methods like the gene expert or a positive PCR, are we starting ATT? No, we're not. Then how do we take and how do we find grounds? Because we know that the disease has got a peritoneal spillage, a tubal spillage, and to really say that this spillage will not be happening in the latent phase or early disease is what we don't know. So what we do is better to take biopsies or peritoneal washings from multiple sites, because we know that the disease is possible. So if you get a positive PCR on an endometrial sample and you're getting a positive PCR also on a peritoneal washing, you're understanding that there is a disease which could be in early phase or perhaps in a latent. And that's why it's persisting. That's why it's spilling from the tube. That's why it's hanging down and going. So in those cases, it becomes very easy to justify, because giving anybody antitubercular treatment is really, really, a nightmare. Ask patients who take ATT, the side effects are so huge. So you have to be very judicious. And what's the data coming from Dr. Jindal's work and Dr. J.V. Sharma's work is that the 30 to 60% of tuberculosis is actually picked on lab diagnosis. And I will share you some of our works also. So then in that case, I think it becomes meaningful because we anyway are putting in a scope for or a laparoscopy scope for working for infertility. So another patient, this is a patient who is a doctor's a cousin who came to me, one of my residents' cousin. Again, she was married, infertility. She never told her in-laws that in her childhood, and this is what she shared with us, that she had taken ATT twice. She was married, the ATT had been finished. The last ATT was taken 5 years, that is well before her marriage. So when I sort of worked her up, I knew that this information didn't come very easy. This information came later when I saw her HSG, and she shared, yes, what we saw was there was distal hydrosalpinges. Now, the tubes were patent though, and she had taken 6 to 7 cycles of ovulation induction. So this is the finding. You can see there are distal hydrosalpinges here. And so what we did, what was the next step? Now, with this HSG finding, do I give her ATT? Well, no, next step would be to put in a scope. And when I put in a scope, you can see typically adhesions between the omentum and the parietes, classic perihepatic adhesions. And when we, again, this patient herself was chart accounted, a very high profile family, and then she had to request me, please don't share this information with my in-laws because so what we did was we immediately did adhesion lists, and when we reached there, we found that there was those hydrosalpinges. Again, had to do an IVF for her because we know the tubes, even though were patent, if we want to do an IVF in such patients, these hydrosalpinges would increase. We did a proximal tubal occlusion and went ahead, and she had a pregnancy. So these are the images which I wanted to show that, even when they are treated, the damage has happened. We don't know whether the disease may be latent or not. Certainly, this is a ground to give her ATT because she will be going for an IVF cycle. So, of course, should we give an ATT or not before her? These are questions, and I think I've answered is how we manage. But again, I think one has to be individual, have to be judicious. And it is one of our good publications we got in the JMIG, a Journal of Minimally Invasive Gynecology, with a high impact, where we found that when we did, these were 224 samples from the 375 patients who were screened for infertility. We found only 2% were positive for conventional as compared to 58%, a very high PCR positivity rate in our case. So did we give to all these patients ATT? No. We actually went ahead and did laparoscopy. And when we found that of these, eventually only 39% of these 40 PCR positives, 9%, there was finding in 39%. So 1/3 of these patients turned out to. So imagine giving ATT to 224 versus giving 1/3, or rather 1/4 of them makes a big difference. So you're actually reducing the complications or compromise of ATT. And we found that the kappa agreement, that means, is suggesting that there is a fair degree of agreement between PCR and laparoscopy. So putting in a scope actually gives you a lot of reason to give ATT, or justifies your reason to give ATT. So if we say PCR standalone is a diagnostic test, no, it is not. If you add laparoscopy, it improves the diagnostic yield, and also referring these patients to a center where, I may be an infertility consultant, but I don't know what laparoscopy is. A PCR positive. So why not refer to my colleague or my senior who can do a laparoscopy and at the same time treat her also, i.e. do some adhesion list. So I think this becomes very important. And therefore, when we have to give ATT, I think it's paramount that when the results are positive with PCR, please put in a scope to improve your diagnostic. This is another interesting case which we came to us, was planned for IVF, dual factor, scanty periods, AMH good. But what was the problem? That's not uncommon when we get thin endometrium. We kept on giving her estrogen priming, but the response was very poor. Endometrium wouldn't go beyond 4.5 millimeters. So what do we do? Do we do anything? Or do we have options? Because thin endometrium is a very big challenge. And this is the way her endometrium was. The reserve was borderline or good or whatever we can say. We know the tubes are blocked, but this is when we are giving her, and every time when we gave her, excess of estrogens, there would be fluid which is appearing. So these are some of the findings that come to us. And this was her look when we put in the endometrium, the hysteroscope. You can see how chalky white is this endometrium because it's got adhesions. So what do we do when you have endometrium? What are your treatment options? I know these are things which you're all trying, but does it really work? Does aspirin, estrogen, sildenafil? Very little response come, because a healed endometrium, which is healed by adhesions, healed with instruments, would really give you any good with these kind of therapies. But what has really come up, and I think we would like to share that we have just been recently granted a project from the ICMR where we are looking into PRP versus stem cells in these patients who have thin endometrium and adhesions, and then we may perhaps not find an answer, maybe give an answer, or realize yes, it works or doesn't work, because research doesn't mean coming up with saying yes, this will work. This may not work, so we can at least tell not to give PRPs, or rather give stem cells. Now, stem cell is something which is in a way, and what kind of stem cell we use? We're using bone marrow derived stem cells. Should we give it just in the uterine cavity? That means just look at intrauterine insemination, or should we put into the subendometrial space, or put it into the uterine artery? Now, this is a pilot work which came from China, where they looked in transfusion of PRPs, and they found that there was an improvement in the ongoing pregnancy rate, with an average increase in the endometrial thickness was 0.6 millimeters. So 0.6 may be very minimal, but this improvement led to a slight improvement. So this paper is small, but it's just showing some improvement. Again, this is a paper where they derived the autologous stem cells from the adipose tissue. So you can get them from either bone marrow or from the adipose tissue, and they tried, and this paper is again a very small paper coming from Ukraine. They showed that there was an improvement in this. So just 19 patients, very small, they got pregnancy in 13, and 11 was after embryo transfers. So again, these are some very small papers and data, but we can't say it would really work. So what was there is that they were putting these endometrial adipose stem cells, some endometrial linings, because they feel that putting in the uterine cavity, intrauterine, does not really work. Again, pilot work which is done from the iGenomics group, which is Carla Simon and Antonio Pellicer from Spain. They have been doing this, and this pilot work has shown promise. And they're now doing a large trial, which is collaborating with the Harvard University, where they're putting in bone marrow derived stem cells into the intrauterine infusions by doing uterine artery embolization. Very, very invasive. But then these are not patients which are getting from tuberculosis, because in Spain and US, you will not get patients of tuberculosis. They are looking at non-tubercular. However, can we say that this is the way it's going to work? We really don't. So what is the prognosis of these patients? Well, conception may happen if there is up to 20%, but will always be a good conception if the endometrium is not damaged. However, it will be very low if there is a damaged endometrium, i.e. there is a thin scarred lining, and this is what we call it, because they are irreversible damages occurred. There are distorted cavities, because you may create an embryo, do an IVF, but will that embryo, will that seed implant, is $1 million question, and that doesn't happen in a thin endometrium. So I would just like to end here by saying that the conventional tests for tuberculosis have got a very limited value. Early diagnosis by using molecular tests and endoscopy is the key to diagnose. Healed may not benefit, like in IE, if you have got an Asherman and there is advanced disease, then even if you give ADT, it's an irreversible stage. You can't do much. Of course, we really need more newer markers for diagnosing. We don't know. Maybe there is an effort to do NGS based, which is next generation sequencing based test. But these are all very controversial things in terms of saying, well, these NGS will work. And there are many, many issues on managing these patients, which we really need to have more data. So I will just end my talk here and take whatever questions that come.
Yeah, Prachi, can we have questions, please?
Yes, I'm putting the questions.
Okay, please. Okay, yeah. Yeah, ma'am. Dr. Neena, ma'am, one question is there on the screen.
Yeah. Is it okay? It's it's in the chat box, right? Okay. There is a question from Dr. Kumar. If the patient of endometrial tuberculosis conceives naturally after 1 month of treatment, then how long to continue ATT, and what will be the regime after that? I think this is a very pertinent question. We do get, as I said, when the patient conceives on ATT, because we know, and I didn't touch because I'm talking on infertility. Actually, if we look at it, we even get patients with tuberculosis having miscarriages and recurrent implantation failures. In fact, there is a high percentage of them having ectopics, and also this pregnancy will go further. So in such a case, if she is getting an ETT and she conceives, it's a good idea to continue the therapy. And what is recommended is that we give them safely INH, because that is the one which is recommended. Don't give them pyrazamide or streptomycin or the likes, because that's something which we are not very sure, because they have teratogenicity. But what we can do is you can give them INH and rifampicin and complete it. Definitely take them in the first trimester, and that's it. Of course, we need to inform the pediatrician when this baby delivers, because there may be a place to give them ATT. The pediatricians or the neonatologists may consider it, but it is safe to give INH, is definitely very safe. So, times we even give up to, if she's just started 1 or 2 months and we complete, then we can give it in the first trimester. That's what is advised. I hope I've answered your question. So Dr. Apeksha says okay, there is a query that she said laparoscopy and hysteroscopy when we suspect TB, not exactly in active phase. I think she means that shall we go for laparoscopy hysteroscopy when we suspect TB, not exactly in active phase? So yes, obviously, if she's active disease, she'll be picked up on conventional. But even if she is active and you put in a scope, I have seen situations where I've seen a granuloma right in a hysteroscopy. I don't have that video because it's not a very nice video. Yes, you may even put in a scope, but that's very unusual or a rare type of scenario. But I'm not very sure what you're really wanting. You want to put, should I put in a scope in the active, or can I really go in if it's not active? Well, laparoscopy, hysteroscopy, after you put in, will you be able to diagnose as active or a latent kind of a disease? So putting, it makes sense, but yes, you do get surprises when the disease is active, and I have diagnosed a granuloma even in hysteroscopy. Now, yes, there's a question from Dr. Smita Jain. What is PAMP? I don't know what is this PAMP. It's a gimmick. I don't want to name people because they are my colleagues. What is PAMP? I don't know. You put in literature, but there is this whole group of doctors, I would say geniuses, who are selling PAMP. What is this? I've shown this to the best, molecular, specialists from countries, including AIMS and PJ Chandigarh, and they say, I don't want to use those words, but there is no place this test is sort of recommended. If this test is known, why don't they publish this test? I really don't understand. And PAMP positive making diagnosis for treatment is a shame. So Smita, I hope I've answered. And I know where you are getting this test, from which part of the world or which part of the country. So again, how useful is quantiferon gold in India? I think I've already told you, these are IGRAs. So quantiferon gold or test in tube, they are all a kind of, ancillary test. And as for WHO says, in developing and low-income countries, they really do not give us any justification to offer them. However, they have not deleted them. I would say if there is a lady who has, because they're costly, quantiferon costs 3,000 to 4,000. So in the last 10 years, I have not asked anybody to get a quantiferon because I don't have any value. It doesn't give me any improvement in my decision making. So why should I waste 3,000 to 4,000? Rather confuses me. So if you're continuing to do it, don't do it with the basis that quantiferon will be a decision maker. So that's how I take it. Okay, Dr. Parvati says that after starting ATT, how much time we wait before starting IV? Well, I think there is no kind of gap. When you've completed, you can take it perhaps in the next cycle, because you should encash rather than wait. Because a lot of people ask me, you give an ATT, will you repeat a EA? Well, certainly not, because there will still be a dead vessel which will be fit. So I think you can go ahead once you complete the next cycle. Okay, Dr. Tanvi Gawa from Delhi says, how effective is menstrual blood TB PCR in suspected cases? Well, really, I think this is again a food for thought. It is not very easy actually, Tanvi, to collect menstrual PCR, menstrual blood. Because if you ask a patient to collect it, there will be a lot of contamination. I didn't get that slide because the time is paucity, but when we did this multi-center trial, which was done at 5 centers, when we did this study, we published a lot of papers from this. I just got one paper in JMIG. We published a lot of work in the European journals with a lot of molecular work on immunohistochemistry. And we had this debate when we were getting this funding. So when we were making our SOPs on how to collect endometrial samples, trust me, endometrial samples, which go inside the uterine cavity through a Carmen's cannula, we were told that contamination of even the Carmen's cannula here and there, or even touching when you're putting the sample in those vials, can be a source of false positivity. In fact, they told us that even the water that they, most labs use, there has to be of some particular quality, because some people may fill in with some kind of. So all those things are very minutely taken. A saline or content in the media or whatever they were taking, we were so particular because we wanted to avoid false positive. If there were so many issues in testing a woman for endometrial aspirate and contamination is a challenge, do you think the menstrual blood will not be devoid of contamination when the lady collects it in a while she's bleeding, and it'll not be touching the hair or the vulval areas? Absolutely not possible. I'm sure it will. So why take that risk? Yes, in an unmarried girl, when you can't do an endometrial aspirate because of that may be, but you the answers, you have to be again be comprehensive. Now, Dr. Adiga is asking, what are fertility rates after treatment with ATT? Again, Prashant, they would really vary. Again, from the works that we have from Dr. Jindal's work and also from Dr. Lani, they were IVF treatments. And the data showed that Dr. Jindal's paper, if you read the human reproduction, that treatment went up to 35%. But mind you, they were all PCR positive. They were not the ones. So again, the treatment outcome would vary, but where the patient is she in the early latent phase? Perhaps the treatment outcome will be very good, i.e. she just has a PCR positivity. And somebody who has had a tubal damage or has an endometrial damage, I'm sure the results will be more. But by and large, I think the data that I picked up, they were varying anything, and the figures I gave were 20%, up to 20% were those patients who actually had a disease which is picked up not just on a PCR alone, i.e. not latent. But yes, her paper reads 34% after 34-35%. Okay, I hope I've answered that. Smita says that there is HSG which is showing the tubal block, one is positive, but RT-PCR negative. Patient can't afford laparoscopy. Shall I give it to you? This is something which is a very, if she can't afford, send her to us. We do it all free. So have friends in a public funded hospital where she can. So we'll send the patient back to you. I would certainly not give you the liberty to start her ATT on the premise that she has this thing. But then the HSG by itself is showing the tubal block. She actually needs a laparoscopy. All you know, this will be a false positive, because if I cannulate her tubes and her tubes are open, she makes a ground for a laparoscopy anyway, because on the base of a tubal block, I don't think we give IVF or any treatment. We still put in a scope, do a proximal tubal cannulation. So tubal cannulation is the treatment anyway. So to anyway put her in. So I hope, Smita, that answers. And in case you have issues, you can send them. You are from Sun City, phase 1, if Sun City believes NCR. So you have the choice of sending her to me. I will still put in a scope, and all you know, she may not have a, because HSG has a false positive of tubal block as high as 48 to 55%. So all you know, she's going to be false positive, and I can, we can do good. Now, Dr. Khanna says that PCR or gene expert is better. Which is better? So gene expert, which was very low as compared to our work, which we are in the process of writing. This paper is already written, has to be sent. We got a very good code because we did PCR and we did gene expert. And what we found that there was a very good concordance as against her work, though the gene expert itself is a cartridge-based test and gives the result early. But if you would say, I would still say PCR, because we have a lot of data, we have a lot of information. Basing ourselves on just gene expert would be a little difficult as of now, because we will have variable data. But yes, if it is a gene expert, the specificity is very high. This is what is even our experience. So if you really want to be very sure, I'm sure gene expert would be the answer. Again, Dr. Nirmala from Hyderabad says, always better to do ATT in consultation with a chest patient, ma'am. In my experience, the patient feels more convinced to continue. Well, right. I think it's again depends on your liaison with your people. If you are good, Nirmala, with people in your setup and the patients who are educated take it better, there's no harm. At the end of the day, we are here to help our patients. It's not that I can say I'm better than my chest physician. Certainly, this combination works better. Please go ahead. So Anju's from Jaipur says that patient have taken treatment in past but show TB-PCR. That's what Anju has told you. Know, if you saw my slides, that what is the false positivity of a TB-PCR DNA? It's certainly there, and the false positivity I showed was 15 to 20%, because DNA will come positive even because there will be dead bacilli. So don't get surprised. This is not a surprise finding. However, as I already said, it becomes very difficult for us to really treat her treated. If she's there and she has got some findings on the laparoscopy, my fear is, now this is already damaged. Should I give her ATT again? I don't think there is any guideline, but yeah, certainly for the benefit of those who are undergoing, if they have some kind of doubts, then I think it's a good idea to get them ATT. But certainly you cannot keep repeating, because this will be a positive DNA will keep coming, because it's a dead bacilli. So this is nothing unusual. Should we be treated? Yes, that's what I would tell. We certainly don't treat a positive PCR if she's already treated. There's no point, because we are going to increase the drug resistance. But sometimes, when we have implantation failures after IVF, then we are forced. And there is a nice publication in another very good paper in Gynae Obs investigation, a high impact journal from Professor B. N. Chakrabarty's group. Not a very recent publication. I recall it came in 2012. And this paper is again a very landmark paper. I couldn't get it. It's there in my earlier, some of my slides. Professor B. N. Chakrabarty's group actually looked at a group of patients where they found, and it's not a randomized, it is a case control study in which one group of patients with positive PCR treated versus the non-treated, they gave ATT just in the IVF group, and they found the implantation rates improved. So I think that paper, beyond that, nothing came. So I think if you use that, then if they're having implantation failures and they have a very nice number, mind you, they've taken only the ones one implantation failures, they didn't take it routinely. So I think it's a food for thought, but it's not very easy to give somebody who's had an AT2 repeat PCR positive to give AT2. But if you have implantation failure, then that paper becomes kind of a must read. So, ma'am, there's another question from Dr. Navina. On day one menstrual blood or TB gene expert, it's done only in few centers. Right. I would just say don't do menstrual bloods, as I said, because of the high contaminations. It's not very easy to say. That was very, very well collected. And if you think there is a woman who's infertility, we do endometrial aspirate with as thin as a common cannula, which is just 4 millimeters, the thinnest possible you can use, and that costs you no money. And the best is do it in the pre-menstrual phase, not in the menstrual, because many times by the time you're collecting, this patient could give you a positive conventional, but that granuloma may be shed off. So why do you want to regularize? So it's for me, I would be mindful, because menstrual blood, there is no data as of now how well it correlates with it. So if you're doing infertility, you're anyway, this patient, I'll trust me, your infertile patients are willing to take any kind of, intrusiveness or invasion for them, as long as you give them on the right path. So for me, I think I'm happy to do it in the aspirate. I don't even need anesthesia. Just give a paracervical, put in the thinnest possible Carmen cannula, attach a 20 cc syringe, suck it out, and that's so simple. I know it is invasive, but it's not all that painful. So I hope I've answered the question. Yeah, Smita says, after how many months of ATT can the patient? I think that answer has been answered. You can take her right in the next cycle. You don't have to wait, because again, if you kind of keep waiting, keep repeating her EAs, they will be showing positive PCRs. Alternatively, I think people are very fond of doing menstrual blood. Actually, I don't have any experience of menstrual blood, to be very honest. So I don't think I'm the right person, because I believe in the science of it. We get a sizable load, but because we have worked very closely with 5 centers and we knew it, we had this brainstorming which was done almost 6-7 months in ICMR, and we came to a consensus from all the best molecular specialists that menstrual blood cannot replicate. So I have no clue, and I would not be suggesting anybody. If you're doing it, well, you're happy, but I won't think that I would take menstrual blood. As I said, the contamination would be so high. Are you confident that the girl is not, or the lady is not going to have that contaminant from the neighborhood or the surrounding, and she's giving you a good sample? So I think if you all are very fond of the menstrual blood, I will not be the person, because I have never done a menstrual blood, and even anybody treated that.
Yeah.
Can we stop here?
Yeah, ma'am, please. We can take offline questions also later on, Prachi, because
sure.
ma'am has to join some other meeting also, that I know. So
Thank
time
you
is
so
there.
much.
Yeah. So
Thank you so much.
yeah, ma'am. Thank you so much, Dr. Neena, ma'am, for your nice, exhaustive presentation. In fact, it was wonderful. Lot of cases were discussed. It was wonderful presentation, in fact. And my sincere thanks to IFS, Dr. Sudha Prasad, ma'am, Dr. Neena, ma'am, again for giving us this opportunity to organize this scientific webinar, Fertility Connect series of webinar. Thank you very much.
Thank you.
Yeah.
Before I end, and thank you us for giving this opportunity where we interact with so many of friends. I mean, I think I'm seeing all the names, and most of them are our friends. And
Yeah.
Across the country.
Thank you, ma'am. And so many questions are coming in, so we'll take rest of the questions
offline. So thank you, ma'am. And in fact, It's a wonderful, working with you to conduct these scientific fertility, IFS Fertility Connect webinar. This is the 15th webinar we are conducting, and the next webinar, I think it is scheduled on 13th of March. So thanks a lot, all of you, for joining this webinar. Thank you very much for your gracious presence. And we look forward for your presence in coming webinars also. That is on 13th of March. So thanks a lot once again. Thank you, Prachi, for helping us.
Ma'am. Yeah.
Yeah. Thank you. Thank you very much, ma'am. Thank you very much.